And so what's fascinating to me about this is I've done it in more people who are not necessarily at risk on paper, is that every once in a while, I'll find somebody who's got a significant amount of coronary artery disease with no risk factors, decent enough cholesterol, active, and not necessarily a family history. And the family history could be limited by what we affectionately call in epidemiology competing risk, which means you died from something else before the outcome that we were looking at was interest. So their parents could have died before they were old enough to have a coronary event.
Welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. Enjoy the show. Today's episode is sponsored by Biography Health, where healthcare meets personalization. With their DNA-enabled blueprint, Biography Health empowers you with a health plan based on your unique DNA, aiming to prevent disease and extend your life. Take control of your health journey with a plan as unique as you. Visit biographyhealth.com and start your personalized healthcare journey today. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine. In this episode, we're joined by Dr. Philip Bretsky, a board-certified internist from Santa Monica with expertise in epidemiology and Alzheimer's research. Dr. Bretsky discusses how precision medicine is transforming healthcare by integrating genetics, biomarkers, and lifestyle factors. He explores the challenges and opportunities in implementing this approach, the evolving role of general practitioners, and how patients can advocate for personalized care. Dr. Bretsky also shares valuable resources for both health-conscious individuals and primary care providers interested in precision medicine. Join us for the insights into the future of healthcare and strategies for better disease prevention and treatment. Hey everyone, welcome to another episode of the Precision Medicine Made Simple podcast. I'm your host, Taylor Koo, alongside my co-host, Dr. Stanford, and today we are excited to have a renowned expert in internal medicine, colleague, and friend joining us. He is a board-certified internist based in Santa Monica, California, and a diplomate of the American Board of Internal Medicine. He holds a Master in Public Health from Yale University, where he earned high honors for his research in epidemiology. With a career that spans Alzheimer's research and precision medicine, his focus is on delivering personalized care to his patients. His achievements, including the Irving Lasker Award and the Scholar in Training Award, and his global upbringing has shaped his distinctive approach to healthcare. We'll discuss how precision medicine is transforming patient care, why doctors should adopt it, and provide tips for patients on advocating for their own care. Without further ado, please give a warm welcome to Dr. Philip Bretsky.
Thank you. That was very kind.
Dr. Bretsky.
Thank you, guys.
Welcome. And to really kickstart this off, you two, Dr. Stanford and Dr. Bretsky, have gone way back. And so I'm curious to know how you two got connected and then now have eventually evolved this relationship into working together in Biography Health and just being colleagues and friends.
Yeah, well, I actually remember it very well. And I think perhaps, I think I really encountered Dr. Bretsky the first time. Maybe we shared a patient at Cedars briefly, but the thing I really picked up on was his incredible background in terms of having done the physician scientist training program over at USC and his, PhD in the the genetics of breast cancer, and as you mentioned, the epidemiology and all that. And so Dr. Bretsky and I are actually in a fairly small fraternity of people that have completed the physician scientist training program that did not go into academia. So in other words, did not attach ourselves to like a UCLA or USC or a Yale or Mayo or whatever. And also doing internal medicine without doing a fellowship beyond that. That's a little unique with someone with as much training as he and I have. So as soon as I, got wind of his background, I thought, gosh, we are kind of birds of a feather. So I think we should meet up. And I believe I texted or called him and I said, hey, let's get together for lunch. We have a lot in common. And we had a great conversation and we've been thick as thieves ever since. I think that was probably about 17 years ago or so.
17 years ago. Wow. Is that correct? Is that accurate from your perspective, Dr. Bretsky?
Yeah, well, it's where I was. I mean, Dr. Stanford was attending physician at that point, and I was still a resident, and sort of trying to figure out sort of what it was I wanted to do, and it's funny because people ask me, was this always kind of your plan? This where I am in private practice and as a solo practitioner was never the plan. This is not where you see folks, and I think that's what Dr. Stanford saw as well too. Most MD PhDs are in academics. I always thought his PhD was interesting from an engineering background because we had, when I was at SC, we had a group that did biomedical engineering at Caltech. So I just stayed at SC because I was regular smart. The super smart guys working on and women working on heart valves and biomedical engineering went to Caltech. And so that background was definitely was interesting. I mean, the original plan for me was to play third base for the New York Yankees, but a sort of lack of athletic prowess cut that off pretty fast. So and then not to further specialize, and especially the training program that I was in at Cedars-Sinai, I think I was one of 2 out of 28 that didn't go into a specialty. And so again, that partially I never found anything that sort of interested me enough to want to do that full time. And so like hematology, oncology scared me. I really liked the ICU and critical care. That also scared me. Just because you learn a lot, and I didn't see being able to make that sustainable for what I wanted to do. And so to see somebody who was sort of ahead of me, kind of carving out a path on their own was very appealing.
Got it. And so Dr. Stanford's then, and correct me, I'm just trying to get the timelines correct. Then did Dr. Stanford already have BHIPM created for his own practice? No. Okay.
No, at that point, I was building a practice in hospital medicine, which was also something that really didn't exist much prior to getting into it. So that was pretty interesting, and how I got to know a lot of the residents during their training, because on any given day, I would have 15 or 20 patients in the hospital, and it could be that there would be a resident involved here or there.
Got it. And so I'm curious then, Dr. Bretsky, I mean, based on your research as well, what was really that, maybe it's experience or culmination of experiences that then sparked your interest to then lead more towards this side of personalized care to deliver to your patients then?
Yeah, I mean, it's really a process. And I think the way that Dr. Stanford and I kind of both ended up here, again, with me in the trailing edge, like I don't want it to seem that I'm sort of leading this process in the same way that he started sort of the hospitalist medicine. He's really been a trailblazer in this as well too. But I think the way that we're trained is to diagnose, identify, and treat disease. We're never trained to prevent disease, which is always sort of strikes me as a little bit funny, because my PhD is actually from USC's Department of Preventive Medicine. But the reason I got into clinical medicine as opposed to research is because one of the things that was dissatisfying to me about epidemiology is that you would look at sort of different risk factors. For me, I looked, primarily studied breast cancer, and but you were looking at it at a population level. And so you'd have these sort of rare processes, everything's at 100,000 population, so 3 or 5 at 100,000 population. but you would see that one person. And yes, this is something that occurs rarely, or these are the different risk factors. And even as pejorative as like smoking and lung cancer, even that relationship breaks down the second you see somebody who has lung cancer who never smoked. So that's sort of how I got into clinical medicine as opposed to research. And then with that, really you start out by treating disease. You don't start out by preventing disease. And I think as I've moved along in my career and now happily mid-career, it's a good flex point to really begin to look at those things that you can do to stop things from happening.
And so then you were more trying to treat these diseases, and you saw all these different obstacles where treating the disease just when the disease came wasn't enough. And then that's where that mindset shift in framing then came to say there has to be something different. And now I wanted to explore this.
Yeah. Like,
then.
Yeah. And to give you an example, I think it's really well articulated. It's a reactionary position that you're in. So I think one of the real sort of shift points for me, I would say maybe 5 years ago, if I had a patient that had a cardiac event, I think most physicians are like this, we're hard on ourselves. I would say, what did I miss? Right. So I go back through the chart and did they have a stress test? When did they last have their cholesterol? What did I do wrong? And I really wanted to move away from that feeling. And, fortunately, technology has come where we have tools that we didn't have 5 or 10 years ago, or we had those tools, but they were prohibitively expensive. So now I kind of found myself in a point where I'm like, okay, have I looked at somebody's Lp(a), which is a very atherogenic cholesterol? Have I looked at their ApoA? Have I looked at their ApoB? Have they had a coronary CT? And then now to add on top of that sort of a genetic risk profile with polygenic risk scores. And again, this is the crux of epidemiology, where you start to look at gene environment interactions, gene interactions, even gene medication interactions. It's a whole new world. And I can stop saying, what did I miss? And say, I know what's coming. And I can communicate that to the patient. And we can come up with a preventive medicine plan as opposed to a reactionary plan. And you can treat heart disease after it happens. It's not preferable. It's a lot more work, but again, I think from how I was trained and, again, in the hospital, you see disease, you don't see health. So it's a real frame shift.
Yeah. And what I loved about that is and I can imagine there's sort of like a vulnerable experience in backtracking what happens before then and how we got to this point too, and vulnerable and very genuine to say, where did I go wrong and what did I miss? And I really do commend that way of thinking to be able to try and see what could we have changed so this can then not be prevented. And was there somebody that you looked up to then that sort of dictated that mindset shift, or was that always really there for you as you're in practicing medicine in terms of just going back and looking at different case studies and trying to find how we got to this point?
Yeah, I mean, I think, honestly, there's a couple of like sort of role models that are out there and they're fairly well established. I mean, one person that's local, that's here in Los Angeles, is David Agus, who wrote this book, kind of and he's a urologist and concentrates on prostate cancer.
I didn't realize that. I thought he was an oncologist, but he's a urologist.
Yeah, he's a urologist. Yeah. So,
wow.
And he does things where he look at the sort of genetic array of prostate tumors. So what we have done traditionally with prostate cancer is a great example of surveillance and trying to prevent something, because we do have a PSA. There's a rectal exam in the, when you see folks in the office. The PSA is not a great test. It's a test that we have. But he kind of took stuff to that next level whereas I would sort of identify somebody at risk, or also prostate MRI really came to the forefront in the last, I would say, 5 to 10 years, where that imaging got to be really good so we could distinguish between what was benign growth of the prostate versus a cancer, target biopsies, and then have directed therapy. Nobody was looking at the tumor genotypes, but he was thinking, like, if this doesn't work, what am I going to do next? And that sort of got back to the question of, like, what did I do wrong? He was already ahead of the game, saying, like, I'm going to hedge here and assume something might go wrong, right? Or I'm going to give my patient the best chance to succeed, which is a less pessimistic way of saying that. So I think of folks that, you know, and he's here in LA, and like, I have patients with him, and to have that kind of experience is really neat. But again, he was looking at it, you know, again, specific to prostate cancer. And I think the thing that Dr. Stanford sort of introduced and is really looking at this as a global genetic kind of array, and not just keeping ahead of one thing, which is amazing if you can do that, but trying to keep ahead of multiple things, which as a general practitioner, that's kind of my job.
In Dr. Stanford, did you know Dr. Agus as well? Have you connected?
Yeah, I met him.
Oh, okay, nice.
A really funny story to tell, but I won't tell today. But no, he's great. He's had a couple of best-selling books, and actually, from my interactions with him, and just kind of following him, I think he has broadened out. They have that Ellison Institute of Technology or something, which is really oriented around wellness. He's definitely a leader in that, and I would say that he had a significant influence on me as well. And his book End of Illness, I thought, was really good. I can't remember the other one, but yeah, no, he's great. And one thing about how that folds in with, like, prostate cancer. So, for example, Dr. Bretsky identifies a patient, and let's say that person progresses to getting a prostate biopsy, and there's something called the Gleason score that assesses what the risk is. Now, that's straight microscopic pathology, right? But now, in this day and age, they take that same tissue and they send it off for genetic profiling. So now you have genetic profiling plus a Gleason score, and you know whether it's going to be safe to do the watchful waiting or if you need to be aggressive. So that's the whole thing about personalized precision medicine, is you personalize it, you individualize it. What's this person dealing with? And then the precision medicine, what are the tools of precision medicine that we need to apply to help this person? So that's a great case in point. And I think that I keep wanting to call you Phil. So can I call you Phil? So I think when you're I think that the scientist part of Dr. Bretsky really comes into play there, with why he is retrospective, introspective about how he could have handled the case, or at what point could something have been done different that may have changed the trajectory. I think that's a science approach, and I think that's the really cool thing about being a physician scientist. And I also want to say that I don't think it's a coincidence that both of us stopped at internal medicine instead of subspecializing. I think that's also kind of a more science-oriented thing from this standpoint. There's no one organ system I find necessarily that much more interesting than others. It's everything together, and how does it play together? And how does this complex system, which is the human body with all these different organ systems, how does that play together? To me, that's much more challenging and higher science than looking at one disease process and one organ system. Not to disparage people that do that. That's just isn't, from a physician scientist standpoint, that's not for me.
No, and I think that's a great point, Dr. Stanford, that interconnectedness. Again, when I was doing my PhD in breast cancer, I was fortunate enough, the group at USC had really developed the hormonal model of lifetime estrogen exposure, driving your breast cancer risk. And this is very well worked out from the age at first menarche, when you first start having regular periods, to the age of menopause. So if you are in a longer horizon, that is sort of earlier onsets of periods, so later onset of menopause, that's a longer lifelong exposure to estrogen. That increases your breast cancer risk. Also your age at first full-term pregnancy, weight, all of these things can be put together kind of in a model, which is very interesting, until you have a woman in your office who has terrible symptoms associated with perimenopause or the menopausal transition. They have some cardiac risk factors. Maybe they have breast cancer risk factors and ovarian cancer, but how do you put all of those things together in a cohesive whole? And what I find as a general practitioner is that I have patients who come to me and they say, well, my breast surgeon says this, and my cardiologist says this, and the OBGYN is worried about my bone density. And how do you put that together for a single person who has all of this sort of complex risk? And on top of that, they feel terrible, right? So, and I tell people, like, I don't want you going through life with a reduced risk of disease and feeling horrible, right? Like, that doesn't seem like a lot of fun. So at a certain point, that's counterproductive. So, and again, but it's been very difficult until something like you have tools like biography and DNabled to be able to put an umbrella over that. And it is a little easier. And again, as Dr. Stanford said, not to disparage people who specialize. You can do it if you're looking at one disease process. The mathematics are easier. But when you start to put it into a multivariate model, it's more complex, and that's interesting to me.
Yeah, and I was going to say, so now speaking to both of the general practitioners here, has there been I can imagine as a patient, it's pretty overwhelming to see all of these different types of risk factors and almost feeling powerless in trying to figure out, okay, like, well, I guess I have this. It's sort of inevitable, because in my mind, and what I'm thinking through is that the general practitioners have so much power and responsibility to then sort of drive the attitude and approach that people take towards their healthcare then. But have people been receptive to this type of approach more so, or people more just accepting of like, oh, this is my fate, like, I guess that's what it is. I'm just going to continue with the same lifestyle factors that I've been going through.
I think when you do the whole genome sequencing and you get an idea of the person's genetic risk across a lot of chronic diseases. So in other words, having the ability to predict future risk of most of the big chronic diseases, cardiovascular, neurodegenerative, cancer, metabolic, it really helps set the framework. And of course, you are going to see overlaps there. So there's certain genetics that make neurodegenerative disease more likely, and also cardiovascular disease more likely. And there's metabolic problems that cause increased risk of all the other three: cancer, neurodegenerative, and cardiovascular. So when you have these tools of personalized medicine that you can understand the individual, it helps you set the Rubik's Cube, so to speak. It's like, what do I need to do to get this person squared away? And patients love it, to be honest with you. I mean, it's a little self-serving for me to say that, but I think that patients out there have an idea that more can be done than is done in the current healthcare paradigm, the reactive, as Dr. Bretsky would say, break and fix system, I like to call it. You can be predictive, which allows you to be proactive, to prevent or delay onset, or at a minimum, catch the patient at the earliest moments when they transition from health to disease. And one of these disease categories, because as Dr. Bretsky says, that's when it's far easier to deal with. It's far easier to deal with someone with insulin resistance and bordering on pre-diabetes rather than someone with full-blown diabetes and complications of it. Same with cancer, stage 1 and 2, much easier to deal with. Neurodegenerative disease, including dementia, much easier to deal with at the very earliest stages. So you know what to do to delay onset, slow onset, even reverse.
Yeah, I mean, I find patients that have sort of more information, really can prioritize that, and obviously that's something that I try to help with and not muddy the waters for them. And I think folks have a sense of it as well too from family history, which is a fairly crude sort of genetic marker. They're like, well, my parents had this. My siblings have this, they have, and then have different, they'll sort of allude to kind of different lifestyles, whether that's generational, geographic, or just sort of personal choice lifestyles, as well. But one of the stock lines I use for my patients when I talk to them in the context of kind of an annual wellness, is I said, look, with this exam, and laboratories and other investigations that we do, I said, we look at everything and we look at nothing. And a lot of that stems from my scientific training in epidemiology, where we talk a lot about bias. And in this case, it's statistical bias. And so everything from recall bias to what sample you're collecting bias, you can add a lot of noise to the system. And so by pulling back to, again, look at and this I think is also the neat thing about general practice and internal medicine, we're really looking at the whole process, and we're looking at the whole person while looking at nothing. So I don't want to bias myself kind of going into that. And a classic mistake that clinicians make is something called anchoring. And I think I sort of probably alluded to this a little bit when I was saying, what did I do wrong? Like, how was I anchored? Like, where was I in that moment that I wasn't seeing something or I wasn't prioritizing something? And you really do, Taylor, use the word, sort of be vulnerable. You got to get out of your own way sometimes. And sometimes I accomplish that by having another physician involved and getting an additional opinion, which I think is, second opinions are great. I always call them additional because I don't want to minimize that as second opinion as well. But having that sort of, again, that genetic background in an array really gets you out of your own way. And it forces you to sort of check what it is that you're doing and making sure, and people have limited time, limited resources sometimes, and you have to prioritize what you're doing.
So with I guess, this idea of anchoring and also this number of biases that can come into play when taking a look at just the entirety of, let's say, a patient, do you think that is also part of the reason why it's become an obstacle for other providers amongst your peers that have been able to implement this level of personalized care into their practice then? Is that like one of the obstacles that's holding them back?
I mean, it's hard. I mean, I'm fortunate that the way, my research background, I happen to be right place, right time. I mean, I spent 2 years at MIT Genome Center when they were sequencing the human genome. I had nothing to do with that, but I got a front row seat. And it was amazing to see what they did. I mean, I remember when we thought there were 100,000 genes in the human genome. It turns out there's 30,000. And that was like stunning. That didn't mean anything to me at the time, just only because of the depths of my ignorance. So I think I've, again, been fortunate to have a front row seat to that. But the human genome was sequenced in 2000. We're now almost 25 years down the line, and we're now only really having some serious applicability to clinical practice. And so I think it's probably a shortcoming in our training as clinicians, to be able to, how do I implement this into already complex clinical practice?
Yeah, and I'd like to just touch on that also. So I think that doctors I mean, definitely training doesn't prepare you for personalized precision medicine. You're not going to have the background in necessarily in genetics or in data science or in statistics to understand every single thing. But the bar is not that high to pick up a cursory enough amount of knowledge in order to use that. But I think that limitations on doctors and their practices, et cetera, they're having to see so many patients and they only have this much time with every patient. I think that those are the bigger obstacles. So it's really the doctor's ability to spend the time to pick up this knowledge and add another element to their practice. But what I would say is that when we were trained as doctors back in the day in medical school and residency, we're trying not to look at any one particular thing to avoid that bias. You see someone with a positive urine analysis, you go, okay, well, is this a UTI that needs to be treated? Well, you look at a whole lot of things. The patient's symptoms or white blood cell count. Do they have a fever? Do they have pain? Et cetera, et cetera. We don't look at any one thing. You try to bring it all together and have that drive your clinical decision making. And they call that kind of thing a Bayesian analysis, a Bayesian logic path, where you're taking pieces of evidence, assigning weight to it, and going to a clinical decision. Well, I would say that personalized medicine just extends upon that. So, you have all that usual kind of data that you're using, but now you have elements that allow you to be predictive, which is the genetic analysis, the family history, the patient's past medical history, and you just fold all that into your decision making, and it allows you to shift the paradigm from being reactive to proactive.
And so are you all starting to see a trend of data-driven decision making then when it comes to giving out clinical recommendations and medical advice, not just, I guess, within preventing chronic diseases, but maybe even lifestyle factors? Like what about diet, nutrition, exercise factors? Have you all been seeing that as well?
I mean, I think one of the major, again, sort of philosophy shifts that I think occurred really sort of as I was training was the move to what's called evidence-based medicine. Again, that's where you're using basically, population data to drive your clinical decision making, which is great in the aggregate and makes sense until, as I talked about before, you're dealing with the 1 in 100,000 people that's sitting in front of you, and all of that data goes completely out the window. So you do have to be a little bit flexible. And I've had a couple of interactions where this has come to sort of the forefront. And one of the most memorable ones I had was actually with an oncologist, Dr. Alexandra Levine, and she ended up, she just retired and was the president of City of Hope, which is a fabulous cancer research institution here in Downey. She was also walk the walk and talk the talk and taught at USC the Introduction to Hematology Oncology class of first-year medical students. And I mean, she's a giant in the field. And I remember asking her, like, as a scared first-year medical student, I said, Dr. Levine, how is it that you can give a chemotherapy to a patient that works 10 or 50% of the time? And I remember her answer vividly. She said, because you believe 100% it's going to work for that patient. And if you don't believe it's going to work 100% for that patient, you have no business giving that chemotherapy. And this is why she's Dr. Levine and the rest of us aren't, because that's how she approached it, right? She was able to take that evidence-based medicine, which in the aggregate, you'd say, there's no way I'm giving that person that chemotherapy. It only works 15% of the time. Like, you're not going to put somebody who's, 150 hitter up when the bases are loaded in the bottom of the ninth. It doesn't make sense statistically, but there is that process then where you can make the flexibility in the decisions. And I think that's hard, especially when you're under the pressure of seeing a lot of patients in a day. If I have a full conversation with a patient about what Biography Health offers, it's 45 minutes to an hour to kind of go through the whole process and have them really understand. And some of it maybe is just me being able to articulate what that would do, but it sets the stage kind of moving forward. And I think that's one of the challenges.
So yeah, I can imagine that is a pretty big challenge and also perspective change if a patient is trying to understand sort of this new way of thinking and this new approach to medicine and personalized care. Do y'all have any case studies or examples then and of course you don't have to use names, but case studies where you have seen these, you have used some of these data-driven decision-making then to then help prevent certain risks that could have happened in their future?
Yeah, I mean, I think for me, the big one that I see is really with coronary CT scans. Mm-hmm. And that is something that I now do more routinely than I ever have before. And the idea there is what you're looking at is the arteries that feed heart muscle to see, is there any calcification or cholesterol plaque deposition, and the two kind of run together, and then which would lead to narrowing or clogging of the arteries or an unstable plaque that could break off and cause a coronary event. And when I talk to patients about it, I say, well, I'm looking, where things are now, but I'm also looking at you in 10 years, because I can from that get a coronary calcium score where I get a predictive, I can get a figure, like what is your chance of developing obstructive coronary artery disease? And so what's fascinating to me about this is I've done it in more people who are not necessarily at risk on paper, is that every once in a while, I'll find somebody who's got a significant amount of coronary artery disease with no risk factors, decent enough cholesterol, active, and not necessarily a family history. And the family history could be limited by what we affectionately call in epidemiology competing risk, which means you died from something else before the outcome that we were looking at was interest. So Their parents could have died before they were old enough to have a coronary event. And so we just don't have that data. And so not that long ago, I have a very, very fit 65-year-old guy who just retired, extremely active, athletically, and had a coronary calcium score that was almost 1,000, and the cholesterol was fine. He had outstanding good cholesterol because he runs all the time, and I said, look, we prevented an event here. He's not anybody who, if you looked at evidence-based medicine based on his LDL measures, would have ever been on a cholesterol-lowering medication. So those are the kinds of things that we can see from these technologies. And then obviously, if you have a genetic sort of polygenic risk score on top of that, you can then really identify these people more readily.
Go ahead, Dr. Sam.
I was going to say, and for some of these things like a coronary CT angiogram, insurance isn't going to necessarily pay for it. And so when you're really doing it in a proactive way, so you have to be thoughtful about who it is that's going to benefit the most from that. And when you can look at the entire data set together, like we're saying, the family history, the polygenic risk scores, current lipid levels, et cetera, it can definitely nudge a patient in that direction and to say, look, this is something that we need to do. We need to establish where you are in this process, because you could be pretty clear. You could be at above average risk, or you could be at a dangerously high risk. And so you have to look at all this information together. And I don't think that the healthcare system, I think if Phil and I had our way, everyone would get a coronary CT angio probably about age 35 or 40 and every 5 years after that. But I don't think the healthcare system is very close to ponying up for that. So you have to use these tools that help you predict that who's going to be of most benefit. And then to answer your previous question, I like Phil. My most common save, so to speak, is people that have under-recognized risk of coronary artery disease. The typical case that he just described in terms of someone that is into fitness, et cetera, and you would think because they are very careful with their diet and very fastidious about exercise, et cetera, that they're not going to have coronary artery disease. But when you see their genetic risk, you think, well, maybe they haven't outrun their genetic risk, and you send them for analysis and it looks so bad. But also underappreciated risk of cancer. I've definitely had more than a few of those, especially with women that have not necessarily BRCA and the like, but have moderately elevated polygenic risk scores. And then you look at them more carefully and yeah, they have dense breasts. They have first and second degree relatives with breast cancer. So through risk modeling, that really ups their risk. And so you treat them a whole lot differently than you would treat someone at average risk. So a lot of this you could sum up to say it's integrating all this information, including genetics, as a big risk stratification exercise.
Now, extrapolating genetic risks then, and wondering if the both of you can dive into what those risks look like and how they're sort of categorized. Because I can understand from, let's say, the labs that they're getting, the biomarkers that they have based on their measurements, it could show an increased risk for this versus that. But then you tie into the genetic risk. I'm assuming y'all are talking about polygenic risk and monogenic risk.
Yeah.
Correct? Can you both dive into what that really means and how that plays into the picture of their whole profile then as a patient?
Well, certainly you're going to look at any big hitters. And, we talked about stuff like BRCA with the monogenic risk. Seems like so far in my practice, I haven't made a new diagnosis of BRCA gene in one of the people I've done whole genome sequencing. We see a lot of the ApoE4, so-called Alzheimer's risk. That's also a pretty significant risk for cardiovascular disease. And that is really helpful. And if you see that, then you're going to be talking a lot. You're going to be looking a lot more carefully at the cardiovascular risk profile and polygenic risk for that. But then you're also going to do extensive counseling because with ApoE4, you're at increased risk for Alzheimer's dementia, but your overall dementia risk can be reduced by really going after metabolic things, exercise, sleep, reducing alcohol consumption, all those other things. Now, to what degree it reduces the Alzheimer's specific risk is really unknown, but it pretty clearly reduces your overall dementia risk by doing that. And so someone that is at an increased risk in a certain area, that would definitely signal to me that you want to be more aggressive about reducing your overall risk.
Yeah, like from my perspective, when I frame, kind of looking at folks again in this context of looking at everything and nothing, there's another great book recommendation besides End of Illness by Dr. Agus is Peter Attia's Outlive. And there he kind of and talks about these kind of four horsemen, right? So these, which is a little bit overly apocalyptic for me. And then there's a lot of crosstalk between the four horsemen as well. But they're basically heart disease, cancer, neurodegeneration, and metabolic dysfunction, which we would lump sort of diabetes in. But as Dr. Sanford alluded to, there's a lot of genetic overlap with those. And so if you begin to look at these things and you can tease them apart and then put them back together, a lot of the advice kind of follows in terms of what it is that you want to do in terms of lifestyle, dietary intake, exercise, and then medications kind of as appropriate.
Got it. And so now switching gears here, and let's say that patients aren't, of course, patients to Dr. Sanford and Dr. Bretsky, but then want that level of care from their own providers. Do you have any tips or ideas in presenting this conversation to, or asking questions to their provider to have, I guess, this level of approach, I don't know if I'm asking the question correctly, but to have this discussion with their providers, any tips that y'all would have to these patients that are listening?
For better, for worse, in the context of how healthcare is run in the United States, patients really do need to self-advocate. I think we don't have sort of a safety net system like they do, say, in other United Kingdom or things like that, which is, again, look, there's downsides to the system that they have as well, too, but some of the basic stuff is provided for. So we have this kind of patchwork system, although I think Medicare is great. If anybody asked me and I wanted to reform the system, Medicare for all in 10-year increments, but I'm not running for office, so I don't have to go through my plan.
I'm voting for you.
I am. Oh, I was missing you on the presidential debate yesterday. What are you talking about?
Exactly. I have more than a 4-sentence plan. But basically, I think patients can start to really delve into this in a conversation with their primary care provider or whoever it is that they get care for. A lot of women get their care from the OBGYN, of starting to kind of look at biomarkers, technology, what's available out there. And then from that, the de-enabled and biography is a logical point that you would arrive at. So we talked a little bit about CT, coronary angiography. We talked about basically Gleason scores and genetic array and prostate cancer. LP(a), which is, again, this very atherogenic cholesterol, ApoA, ApoB, ApoE genotype. Those, it's, not for nothing that ApoA and ApoB, which are cholesterols, are related to ApoE, which is the gene that confusingly has 3 alleles. And that's related to, Alzheimer's and cardiovascular risk. In very few steps, you're at genetics. And so the question then would be like, how do you then integrate that into an overall care plan for a patient? And I think patients can advocate for that for them in a way to have that conversation with providers as they move forward.
And so from what it sounds like, really pushing for these types of screenings and tests then to get your biomarkers. And I mean, would you suggest then going through whole genome sequencing and then sort of presenting this to the provider then and saying, here's my results then, and where can we go from here?
Yeah, I think as long as there's some chaperone in that process, which again, I think is something that biography can provide with the expertise of the people like Dr. Stanford. I think as more physicians and other providers get acquainted with kind of what this can do, they can sort of lead that process. And medicine is the ultimate kind of didactic experience. The term kind of lifelong learning is thrown around a lot, but I mean, the medicine is constantly evolving, and I think physicians and other clinicians are very familiar with the idea of needing to run to stay in place in terms of your knowledge. And then also, I think we're also sensitized and aware of the fact that Dr. Stanford talked about these sort of Bayesian models that come together. I remember really vividly, I went to USC for medical school as a level 1 trauma center, and I did a trauma surgery rotation as a med student. And the chief of trauma asked me in the ICU rounds if the patient that we were rounding on had pneumonia. And I was like, I really didn't have an answer. I said, well, I don't think so. And he looked at me and he said, I want 4 pieces of information from you when I ask that question, right? I want to know what their white blood cell count is. I want to know what their chest x-ray looks like. I want to know what their lungs sound like. And I want to know what their oxygen saturations are. I don't want you to tell me like what you think. He didn't say it. He said it. Actually, that's probably exactly what he said. He wasn't really interested in what I thought. So, but we're trained that way and retrained in this case to take sort of multiple pieces of information to come up with a clinical plan. And that's sort of ingrained fairly early on. And so this idea of implementing new information, especially when it potentially could make your job easier by either preventing illness or identifying it at an early stage, should reap benefits in the future.
And I want to add to that, as far as advice for patients that want to kind of become involved in a more proactive care plan. I would say that the future of medicine is personalized precision medicine. That is the future, and the future is now, but it's just not evenly distributed. I think that there are, in addition to Biography Health and our process trying to make it as straightforward and easy and simple and powerful as possible for the patient and the doctor. It's not every doctor that is necessarily going to be amenable to adding that other layer of being proactive because of the way the current paradigms, the care paradigm, the way it's structured right now, it does not reward that, does not reimburse it, does not provide time for that, et cetera. It's changing, and certainly there are practices that are devoted to it. So one thing I would encourage patients that, and it's not uncommon for patients to know a whole lot more about this than their primary care provider. I know that may sound kind of off the wall. I just had this experience the other day where had a meeting with the patient, the primary care provider, and the primary care provider said that he had heard the term precision medicine, but wouldn't know how to define it. I mean, that's the level of knowledge. And so with that doctor, they're really going to need a platform that just gives them what they need and is equipped with the easy button and has pretty well-reasoned, easy to follow recommendations. And of course, the other thing that I was wanting to say is there are a lot of practices that are oriented toward, I say a lot, probably 5 or 10, maybe 5% of practices are oriented toward prevention and brand themselves that way. So perhaps in addition to your primary care provider, you might need a practice like that to help guide you through some of this personalized precision medicine. But with Biography Health, we're hoping to empower primary care providers to take that step into the future of medicine, and also support these practices that are already trying to orient toward prevention.
Yeah, and that brings me actually to my next question then. Alongside with Biography Health, with providers that are looking to gather and then integrate these genetic insights into patients' clinical recommendations, any tips or resources that they should use or advice that that y'all have for them, that for the providers that are listening to the show and episode, for them to get started and starts the flywheel of slowly integrating this into the practice? Any tips or advice or resources?
Yeah, I think I would go along with Phil, and the book Outlive by Peter Attia is very oriented toward prevention, and it's a fun read. It was #1 on Amazon and New York Times, I think, for a lot of 2023. It's really, some of my patients say it's a little science heavy, but I would also, rather than, in addition to having the book, the hard copy and the PDFs to look at, I think it's a good book on tape. Another one, though, that would help educate doctors is a book by Leroy Hood, another MD, PhD. And he did do Caltech for his PhD, called The Age of Scientific Wellness. And he's one of the preeminent people in the field, just an absolutely brilliant, decades ahead of his time. So that's a really good book, I think, for providers. And I think Outlive is a really good book for patients and providers.
Yeah. And I think as a fiction book, I know they talk about off the wall recommendation. I just finished Abraham Verghesi's The Covenant of Water. And I won't give away the condition that's in there, but he follows 3 generations of family that have a propensity for drowning.
Oh, wow.
Yeah.
Oh.
And it's a fascinating read. And Dr. Bergesi's a vice chair of medicine at Stanford, but he's also an acclaimed author, and this is also a best-selling book. The middle part is a little bit of a slog. It's 9 books, like it's book 1 through book 9, and but it gets really good at the end. So that's
Saying it's the Covenant of Water.
yes, the Covenant of Water. Yeah, so it's set in South India, and again, it's I think it starts in the 1890s and it ends in the 1970s. So, but it goes through the this family with this condition. So, which is and it's really fascinating.
Are there other podcasts or webinars that the both of you listen to as well to keep up with these, let's say, I don't know, articles or new insights or advances within precision medicine or personalized medicine?
I'm glad you asked that because I left that out of your previous question. So Eric Topol, I think both Phil and I would agree. He's a superstar. La Jolla is super smart, very evidence-based, scientifically grounded, and is first of all, just because of who he is, he gets you name it, the most interesting guests out there in terms of medicine and science. And he's a super nice guy. I've met him. And his Substack, I think they call it. So I get his articles. They're really, really good. Very in-depth, maybe more in-depth at times than some doctors would want to get into. But he has done a lot of analyses in precision medicine world. And of course, Peter Attia's podcast is good. What other? And then there's just a lot of these publications you subscribe to. So genetic engineering, Inside Precision Medicine. There's a lot of these email newsletter type things in it. And I would say there's tons of resources out there. You just got to avail yourself to it, and then skim those articles and read some of them more deeply.
Yeah, I'd echo Dr. Topol. He has a great Twitter/X feed as well too, and so those are pretty condensed on there as well too. But he's really an excellent resource and thoughtful.
Mm-hmm.
Got it. Well, I appreciate the both of you for sharing these resources. I mean, this episode definitely has gotten me empowered as a patient, and I hope it empowers other providers to also take that same step in integrating genetic insights into their practice as well. And in case anybody wants to reach out, Dr. Bretsky, what's the best way that they can reach out to you?
So we have a couple of websites. So I have just for me, which is drbretsky.com, and then our practice, which is Santa Monica Primary Care.com. I also have on Twitter as well, and my kids refuse to let me be on TikTok, so you cannot find me there.
Well, we might have to create a secret TikTok account, and
they figure that out. They're brighter than I am.
Got it. I'll make sure all those in their show notes. Thank you so much, Dr. Bretsky. Thank you so much, Dr. Sanford, for this amazing episode, and we'll see everyone next time. Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.